Good afternoon, good morning in certain areas. We welcome you to this IVF Worldwide webinar and this very sunny spring day. And I hope, despite the medical situation around the world, that you're keeping safe and you're social distancing yourself and you're trying your best to help to control this pandemic. I'm Milton Leong, and I'm speaking to you from Hong Kong. Today, we are very fortunate and honored to have Professor Antonio Marca, Professor of Medical and Surgical Sciences, Child and Health, Child and Adults, University of Modena and Reggio Emilia. He is an expert in all fields in reproductive medicine, and today he's going to give us a talk on AMH, the importance of its clinical use. Professor Marca.
Yeah, thank you, Milton. And well, first of all, I would like to say a few words about what is happening all over the world. For sure, after the Second World War, we are facing probably the greatest challenge for humanity. We never thought that this nightmare could come true, but the reality is that in only a few weeks, we found ourselves living in a world of fear and isolation. Here in Italy, the country that everyone loves, the nation of beauty, art, and culture, is experiencing the bad page, the ugliest page of the modern era. We have thousands of affected people, thousands of dead, thousands of patients needing intensive care unit. But also we have thousands of doctors and nurses who are hardly working to save lives every day. We have thousands of volunteers who go out of their way to help the weakest people. The virus is not invincible. We must remain united and optimistic. Together, we will win. Together, we will go back to our normal life. We will go back to having good time with our families and friends in our beautiful cities. Together, we will come back to stay close to each other and to celebrate life. So take care and stay safe, everybody. For those who are involved in IVF and reproductive medicine, we have published a few days ago an article on fertility and sterility in which we report our experience of the last weeks. We summarize there what we did in the clinical setting in order to increase safety for patients and workers. The measures were revised more or less every day and were more and more stringent according to the spread of the infection among individuals. We think this article may be useful for those colleagues living in countries in which the spread of the virus is at a very early stage. Now, let's go to the presentation of today. And again, let me thank Milton and Zeb for the very kind invitation. The topic today is focused on AMH and well, what is the role of AMH in the female population? And I decided to analyze the role of AMH in the general female population and in the infertile female population. So for the general female population, we will talk about the possibility of predicting the age at menopause and spontaneous fertility. For infertile patients, we will see the predictive role of AMH for quantitative and qualitative aspects in IVF. Well, you know very well what AMH is. It is a protein produced by granulosa cells and secreted into circulation. So that's why you can measure AMH into the blood of your patients. And if you look at this curve, this is the decay of AMH throughout female reproductive life. And this decay is very, very similar to what found for the decay in the true ovarian reserve, which is the number of primordial follicles remaining into the ovaries of our patients. And from my point of view, in my view, this is expression of the goodness of this marker when used as a marker of ovarian reserve. Very soon after its introduction into the clinical practice, it was more or less 15 years ago, we understood that AMH may be superior to FSH when measuring ovarian reserve. And this is, I think, very, very clearly demonstrated in this clinical article, which was based on more than 5,000 patients. In those patients, both AMH and FSH were measured, and when FSH was within the normal range, so was reassuring, well, 1 out of 5 women had in reality low AMH, which was indicative of reduced ovarian reserve. On the contrary, if AMH was within the normal range, only 1 out of 18 women had high FSH. And so again, this gives the idea of the superiority of AMH when compared to FSH. AMH is strongly related to ovarian reserve, so it may be used to predict the age at menopause. Why it is interesting to measure, to predict the age at menopause? Because early menopause is associated to reduced fertility and to increased cardiovascular risk and risk for osteoporosis. On the contrary, late age of menopause may be associated to increased risk of certain tumors, including breast and endometrial cancer. That's why we want to predict the age at menopause. And many years ago, it was hypothesized that AMH can be used indeed to predict the age at menopause. The concept here is very simple. For women of similar ages, the lower the AMH values, the earlier the age at menopause. And this statistical hypothesis has been then tested in longitudinal studies. So we have 4 or 5 very good longitudinal studies nowadays. This is just one in which women from the Netherlands, they were prospectively followed up for 11 years and those women experiencing menopause in this time frame were those patients with the lower AMH values. Age at menopause is influenced, of course, by ovarian reserve, but also different acquired conditions may in some way correlate with the age at menopause. For example, smoking habits. The smoking is associated to earlier age at menopause, and body weight, with low body weight being associated to an early age at menopause. So some years ago, we tried to put all this information together, and we created some predictive model in which AMH, BMI, and smoking habit may help all together in improve the prediction of the age at menopause. So, for example, a woman with an AMH at a very low level, at the 5th centile, for this lady, the age at menopause may be 43 if she is a non-smoker, and if she's overweight, on the contrary, maybe as early as 38 if she's thin and if she's a smoker. A very relevant question is whether AMH may be related to spontaneous fertility in the general population. One way to analyze this possibility is to calculate the relationship, if any, existing between AMH and the time to pregnancy. To my knowledge, this is the best study we have today. This is a prospective study, a 2-year follow-up study, very well done, very well conducted in Denmark. We have here a few hundreds of women who were searching for pregnancy. They received the basal AMH measurement, and then they were followed up. And here in this article, authors found that time to pregnancy decreased with increasing AMH. So in some way, this seems to indicate that having IMH may represent a reproductive advantage in the general population. Some years ago, a group of American researchers they designed a very interesting study, the so-called time to conceive study. The objective of this study was to calculate a possible relationship between AMH and the pregnancy test. The main outcome here was the urine positive pregnancy test, and they published in 2011 on Obstetrics and Gynecology Journal the intermediate analysis of this trial. In this study, 100 women were followed up for 6 months, and 63% of them obtained the positive pregnancy test. And interestingly, age, FSH, and AMH were 3 independent predictors of the possibility of having the pregnancy. In particular, having an AMH lower than 0.7 nanogram ml was associated to a great reduction in the possibility of obtaining the pregnancy. But then this group came out with the final result of this trial. This study was very well published on the JAMA article in 2017. In total, they included more than 700 patients in this study. And when analyzing the final results, they could not confirm preliminary results. AMH and neither FSH were significantly associated to variability, to the possibility of having a spontaneous positive urine pregnancy test. And as you can see here, there's huge overlapping between different categories of AMH strata. And so authors concluded that biomarkers indicating diminished ovarian reserve compared with normal ovarian reserve were not associated with reduced fertility. These findings do not support the use of AMH or FSH tests to assess natural fertility for women. We must say here that this study had a very great impact on mass media and on our clinical practice, but here the outcome was not the live birth, but was the positive urine pregnancy test. And we knew how far is the positive pregnancy test from the live birth. Interestingly, the same group published an article on fertility and sterility a couple of years ago. The population here was the same used in the time to conceive study. Here, the patients were followed up to the live birth, and the objective of this article was to assess whether there was an association between AMH and the miscarriage risk in that population. Well, in the time to conceive study, 533 women were pregnant, but in the end, 24% of them experienced miscarriage. And interestingly, authors found that independently of age, having a low AMH was per se associated to a twofold increased risk of having miscarriage. And so authors, the same authors, concluded that while AMH was not associated to fecundability, reduced ovarian reserve may be a risk factor for reduced reproductive potential due to its association with pregnancy loss. And so we may conclude that probably something may be there may be some association between AMH and live birth, and probably this topic is not closed anymore, and still we need some good prospective large study with the main outcome live birth. Let's move now to the IVF female population. In this population, AMH, of course, is useful to predict the so-called quantitative aspect. And you see here what we reported many years ago, what has been reported recently by colleagues in New York. I just want to say that, well, we have hundreds of articles dealing with AMH and the prediction of the quantitative aspect in IVF, and to my knowledge, there is no one single study which could not confirm the very strong, positive, and significant association existing between AMH and the number of retrieved oocytes after ovarian stimulation. That's why you can use AMH to predict the two extremes of ovarian response, poor response and a hyper response, which can be predicted pretty well by AMH. We found a very good rock area under the curve for both poor response and hyper response, which are close to 0.8, which means that you can translate this information into the clinical practice. And that's why you have AMH on as a daily test in your IVF clinic. The good news here is that in the last 15 years, there was a very good improvement in the sensitivity of the prediction of both response and hyper response. And this is mainly due to our improved ability of measuring AMH. This is because of the improvement in the technology in measuring AMH. In 15 years, we moved from the manual ELISA assay to the automated assay, and this led to great improvement and reliability in the AMH test itself. How clinicians may use AMH in the daily practice? Well, this is again a very simple concept here, which is behind this strategy. The higher the value for the AMH, the higher the ovarian reserve, the higher the risk of OHSS. And so you can use this information to deploy strategies in order to possibly reduce patients at risk for poor response and hyper response. Very often clinicians use this information in order to manipulate ovarian response in ovarian stimulation cycles, in order to possibly increase the percentage of women having a so-called normal and safe ovarian response. You have here probably the first experiences published on the so-called AMH stratified care. The concept here is that you can identify 3 or 4 categories of AMH strata, and you may propose different strategies, different starting doses for FSH, different use for generate analogs, again, with the objective of reducing risks and complications. And this is a trial. This is a prospective trial run in Vietnam some years ago. Again, authors identified here 3 different strata for the AMH below 0.7, from 0.7 to 2.1 nanogram ml, and about 2.1 nanogram ml. And for the 3 different categories, they proposed a different FSH starting dose. And this is the result here. The rate of hyper-responders seems to be very, very low. The clinical pregnancy rate very good, and the risk of ovarian hyperstimulation syndrome was sufficiently low, hence demonstrating that in reality, in the clinical practice, you just may look at the AMH value of your patients and you may take your clinical decision. We had the possibility of analyzing again and again the story, and we found that while AMH is indeed the main predictor of ovarian response to gonadotropin stimulation, still age and day 3 FSH may have an independent correlation with ovarian response. And so we put all this information together, and we created a sort of a nomogram to guide the decision of the FSH studying dose in our daily clinical practice. And interestingly, this nomogram has been tested in an independent randomized control trial. The main objective here was to possibly show an increase in the proportion of women with a so-called normal ovarian response. Patients were divided into 2 groups. In one group, patients received gonadotropins just according to female age, 150 if they were young, and 225 units if they were older than 35. In the other group, the dose was personalized according to the nomogram. No differences between the 2 groups in fertilization rate or implantation rate or clinical pregnancy rate, but this was expected since the primary outcome of the study was designed to show differences just in a number of eggs, and this is the main outcome. The statistical significance was reached here when using the personalized dose of FSH. There was a significant increase in the proportion of women with a normal ovarian response, and also we found a significant decrease in the percentage of the so-called suboptimal responders. There was a decrease in the proportion of women with a very high response. Here, the statistical significance was not reached, probably because of the low number of subjects within this subgroup of patients. And what about the relationship existing between AMH and the qualitative aspect, which in my view is linked to the live birth in IVF? Well, according to the study, it seems that a relationship is there. In particular, for women with a low AMH, it seems they may have a lower chance of getting pregnant in the IVF clinic. And this was confirmed in a recent meta-analysis in which 13 studies have been included for a total of 68. Authors found the good relationship existing between AMH and the live birth, but the discriminative ability was not so good. This means that while AMH is related to the possibility of pregnancy in IVF, the power of this prediction, the power of this relationship is not high enough to permit to you to discriminate between women who will get or will get not pregnant following IVF. But AMH is an age-independent predictor for the chance of getting pregnant. I mean, the prediction is low, but in any case, it may add an information. It may add something on the top of female age. And so we found that we can improve the prediction of a chance of live birth in the IVF population by analyzing age and AMH of women as 2 independent predictors. So, for example, even in young women, the lower the AMH, the lower the chance of live birth. And we calculated here this complicated formula. Interestingly, this formula has been independently tested by someone else, by the group of Scott in UK. They prospectively included more than 800 women undergoing their first IVF, and you see here on the x-axis you have the predicted probability of live birth according to our formula, and on the y-axis you have the actual chance of live birth after the IVF. Interestingly, all the points are very close to the line, which means that this model has a very good calibration. In other words, you have here 3 points: old women with low, normal, or AMH. For these women, the chance of live birth was predicted to be low, normal, or good. But in reality, others found low, normal, and good chance of getting live birth. This means that at least in the IVF setting, AMH, having high AMH really may represent reproductive advantage. And this has been confirmed in a very recent and large observation coming from America. This study is based on the analysis of the US registry for IVF. More than 44,000 patients included in this study. And as you can see here, you have here the relationship between live birth and female age. And in green and yellow, you will find women with low AMH, so women with reduced ovarian reserve. So it is very nice to see that in all age groups, even in young women, having low AMH was associated to reduced chance of live birth. Others found that AMH was an independent predictor. The odds ratio was 0.87 for low versus normal AMH values. So we always say that we need randomized trials or prospective studies before being conclusive on some new hypotheses. And we have here the post hoc analysis of the Megaset trial. This is a very nice trial because it is, well, large enough, including more than 700 patients. All patients, they were young. They were below the age of 35. All women were treated with the same ovarian stimulation protocol. All women received the single blastocyst transfer. And in the post hoc analysis, women were divided according to AMH, below or above the median value. So interestingly, women with different values of AMH, they had a very similar age. Let's see the IVF outcome. Well, the fresh live birth rate was significantly lower in women with lower AMH. But again, be aware that the female age here was the same. There was a significant increase in the proportion of women with blastocysts, with suprannumerary blastocysts to cryopreserve, and so expectedly, I will say, the cumulative live birth rate was significantly higher in women with high AMH. So again, it seems that having high AMH independently of age may indeed represent a reproductive advantage in the IVF program. Nowadays, we all are analyzing the cumulative live birth rate as the main outcome in IVF, in the IVF program. And now we also have studies showing a good significant relationship between basal AMH and the cumulative live birth rate. As you can see here, again, even in young women, having high AMH was associated to a significant increase in the cumulative live birth rate. Very recently, we had the possibility of analyzing the relationship existing between AMH and euploidy of blastocysts in PGTA cycles. And we published this article analyzing more than 500 PGTA cycles, including more than 1,800 blastocysts. The objective here was to see what are good predictors for the number of euploid blastocysts for our patients, and we found that female age, the number of mature oocytes, and serum concentration of AMH were 3 independent predictors for the number of euploid blastocysts for our patients. In order to give the idea of what is the weight of this association, we calculated the probability of having at least one euploid embryo for the transfer. This probability is decreasing by 16% per every increase in female age by 1 year. It is increasing by 27% per every increasing in AMH by 1 nanogram ml, and it goes up by 9% per every increase in the number of mature oocytes by 1. Interestingly, these results have been, at least in part, confirmed by an independent group from Toronto, Canada. They could confirm that AMH was independently of age associated to the possibility of having euploid blastocysts. So, in my view, AMH and ovarian reserve, the extent of ovarian reserve may be independently of the number of retrieved oocytes being associated with a good quality and good chance of getting a live birth. So, dear colleagues, let me come to my conclusion. AMH is the most powerful hormonal marker for ovarian activity, and low AMH may be associated with a reduced ovarian reserve and reduced time to menopause. Serum AMH seems not be related to spontaneous fertility in the general population, at least when we measure fertility with the possibility of having a urine positive pregnancy test, but we saw that there is the possibility of an association with the miscarriage, the risk of miscarriage, and so we urgently need proper studies with a live birth as the main outcome. AMH is strongly related to oocyte yield in IVF and to the possibility of having an extreme ovarian response. So it may be the basis for the development of strategies for ovarian stimulation, including the selection and the choice of the proper dose of FSH. Since ovarian response may be predicted still from the first time you are counseling the couple, we can use this information already when counseling, as I said, for the first time the couple. Markers of ovarian reserve may increase our possibility to correctly inform the individual chance of success, what I used to call the personalized prognosis in IVF. The probability of having at least one euploid blastocyst for transfer may be considered a new intermediate outcome of interest. If we can predict this probability, I mean, this may be very useful for both clinicians and patients already at the time of the first counseling, because it is related to the overall chance of getting the live birth. And this probability, other than by female age, is strongly affected by ovarian reserve and ovarian response to stimulation. Thank you very much for your attention.
Well, thank you very much, Antonio. It was really a very, very clear and impressive presentation, because, as you know, AMH has gone through phases. You know, as you said, ELISA method, 2 different antibodies, and now it's only in the last 5 years or 6 years that we have, you know, a relatively, you know, stuff like the same method. And I'm very happy to see that all the data that you quoted are done with this new method. You know, it is, you know, a lot of presentations have dealt with AMH, you know, in a very long, you know, from the early, you know, 2000s, you know, to now. And that, you know, we're talking about a very mixed population, because we're not using the same method. So I'm really happy to hear, and I'm sure all our colleagues are very happy to see all the studies are done with the same antibody. You know, I think this is really, you know, really commendable. And I think everyone that is following this webinar, you know, should be happy that we're no longer talking about historic, the different antibodies. We're talking about a new standardized method. And, and it's studies like yours and the people that you quoted, that has bring this confidence of looking at AMH. I must say this is, highly congratulatory.
Thank you. Thank you very much.
Now, may I just ask a couple of points, and, and I'm sure, there may be follow-up questions from people following this webinar, and, we will organize it and we will follow it, to you, and maybe you can, sort of like answer or through IVF Worldwide, or, just through, personal response.
Yeah.
Now, I think you presented, stuff like AMH, and I agree, AMH is a very important measurement. And in our center, we also measure AMH on everybody. But we don't cut off people with low AMH. There's a couple of slides, that was shown that, if AMH is very low, you recommend, sort of like no IVF treatment. And I think, that may be a little bit too drastic, but that's not your report. So may I ask personally, if you see someone with low AMH, AFC, let's say two androgen follicles, okay?
Yeah.
And but the FSH is normal, okay?
Yeah.
So you would,
very clear. I got your question. Let me say that AMH, as you said, is a good marker, but it is not the optimal one, which means that the prediction power is not 100%. The ROC area under the curve is 0.8, which means that you may have some false positive and some false negative, first of all. Secondly, in my clinical practice, at least at the first IVF, we let all the patients enter, independent of AMH. Even if the AMH is low, but the patient desires to undergo an IVF treatment, we are using this information, as I said, to counsel the patient. We say to the lady that because of the low AMH, with very high probability, we are going to get few eggs. And this is not so good in an IVF program, but we go for the first IVF. Differently, if a woman already had previous IVF, we are using the information coming from a low AMH, well, probably to counsel her, or also regarding alternative treatments, including egg donation. But we never use AMH as a tool to refrain from the first IVF.
Right. I totally agree. I think there's people who use AMH alone to decide on treatment probably, is a little bit too draconian, and I think, then there's give up, a lot of patients may lose, the chance, of getting a child, a child of themselves, and force to go to egg donation or other things. I totally agree with you. Now, let me ask you another question. Just because we are probably talking, a lot of the clinicians are listening to this. Let me ask you, if you do you always use agonists, and so down regulation, or do you also use antagonists? Or do you use also maybe a combination of, say, clomiphene, letrozole, and FSH, so that you bring up both FSH and LH? Do you use all these methods, or primarily do you use agonists, down regulation?
Are you talking about women with low AMH? or generally
Well,
speaking?
in general first.
In general. Okay. So I must say to you that in the last few years, we become 100% center using GnRH antagonists.
Okay.
We are not using GnRH agonists anymore, unless in some rare patients who had spontaneous ovulation or premature luteinization despite the use of GnRH antagonist. This may happen. According to our own experience, in particular women with low ovarian reserve, so women who used to have very high basal FSH and LH level, these patients may be at risk for premature luteinization when using the GnRH antagonist. So in these ladies, probably the use of GnRH agonist may be considered.
Yes, so I totally agree, because especially with patients with low AMH, agonists, takes too long and for the FSH to work, so you end up using a much larger dose. Now, when we talk about dosage, would you, in your practice, and this is, again, just picking your brains, we're having a discussion, in your practice and in your view, people with low antral follicle count and low AMH, would you go for high FSH, like 375, 450, 600? I know there are people who are giving 900 or 1200 units of FSH. Now, would you rather say, oh, in practical terms, I'd rather have less eggs, and maybe the patient won't mind having another egg collection, to have more eggs and more embryos, rather than pushing very, very hard? Because a lot of times when we look at people with very high FSH doses, they may get more eggs, number of eggs, but the mature XM2 percentage is not much bigger. And the good quality embryos is probably about the same, if you only got 2 or 3 eggs. Would you agree with that?
Yeah, sure. Well, in my own clinic, the highest possible dose is 300 units. We never go above 300 units. And I got your point. And I can say you that in the last few years, probably 2 years, we have moved more and more through the so-called double ovarian stimulation, which is, as you said, the possibility of undergoing repeated oocyte retrieval in the unit of time. But again, fundamental here is the correct counseling of patients. That's why AMH or antral follicle count is important, because since from the very beginning, you can inform the patients regarding their ovarian reserve, the chance of getting eggs, the chance of getting pregnant after the IVF program. And you have to inform this challenging group of patients that the journey may be longer than expected, that probably we need 1, 2, 3, 4, even 5 oocyte retrieval or IVF cycles before getting the possibility, a real possibility of live birth. So we have to move from one single IVF cycle to a cycle, a program in which repeated cycles are included.
I think I absolutely agree with you. Antonio, because forcing an ovary to respond, to prepare the ovaries, to prepare the oocytes, you may not get useful oocytes anyway. And I think counseling is really important, because I think patients, you have to look at patients. Say, for instance, some patients have low AMH or medium or high FSH, but they got a lot of antral follicles. And if you wait for these antral follicles to grow, to let them naturally grow a little bit because because the FSH is already high, then you can end up collecting quite a good number of eggs.
Yeah.
And so I think probably your normogram, I find it very, very interesting, very impressed. But if we can also add maybe FSH, or FSH is only a modulator, I think mostly it will be AFC and AMH. But you also look at the FSH to decide when you would start the medicine, and also what dosage you will end up using the medicine. Because if the FSH is already 15, there's not much sense adding medicine at that point. Because because if you give someone 300 units of FSH, and if you do FSH, say from day 3 to say day 5, day 6, the FSH would only be about 12, mostly.
Yeah.
So so
I totally agree with you.
Is very high.
I totally agree with you. I totally agree with you. What is missing, I think, in literature nowadays is this concept. I mean, among patients with low AMH, in reality, we can find different categories of patients. Those with low AMH and normal FSH, and those with low AMH and the high FSH. For this second subgroup of ladies, the prognosis is even worse.
Yes, absolutely. Yes, I totally agree with you. So that's also another take-home message. That if we mix the three things together, we can decide on the regimen of stimulation or the way of how to prepare the ovary, to obtain oocytes better.
Yeah.
Well, great meeting you, Antonio. I look forward to the days. I had a plan to come to Milan in June, but I think I got to move it to maybe November.
I think so. So.
Yeah. Okay. Well, colleagues who are listening to this, Rabina, let's just give Antonio the usual.
Thank you.
Thank you. And also mindful of the take-home messages, and also the last chance. I really believe one should wear masks in the public. So although the coronavirus supposed to be spread by aerosol and not by air, if you cover yourself, it's better, that because you don't know what other people are doing around you.
Yeah.
Thank you very much. Thank you.
Thank you, Milton.
Yeah.
Thank you.